The following podcast is part of a certified educational activity titled BTK Inhibition as an MS Treatment Strategy, targeting smoldering neuroinflammation. Access the entire activity and complete the post-test at peerview.com/DWJ860. Downloadable slides and practice aids are also available.
Just wanted to introduce myself. My name is Jiwon Oh, and I'm a neurologist and MS specialist at St. Michael's Hospital at the University of Toronto, and very pleased to introduce my co-faculty, Dr. Bob Fox, whom you all know from the Cleveland Clinic. And today we'll be taking you through our symposium entitled BTK Inhibition as an MS Treatment Strategy, Targeting Smoldering Neuroinflammation. Okay, so our goals for today are to review current findings about the implications of neuroinflammation on disease progression and patient outcomes in MS care. We'll also discuss the importance of neuroinflammation as a treatment target in MS management. And then we'll end with a discussion of a number of cases where Bob and I will talk about how you might think about using BTK inhibitors in clinical practice, and specifically discuss patient profiles who may benefit from treatment based on currently available evidence. So I'll just start and launch today's symposium by talking about the rationale as to why we are so interested in the MS field in smoldering neuroinflammation, and specifically targeting smoldering neuroinflammation with newer therapeutic agents. I think many of us in the MS field recognize that we're very fortunate to be in this field where there has been a real explosion of therapeutic options in the last number of decades. And this is unique among chronic neurological diseases. And it's to the point now where in most parts of the world, we now have nearly 25 different therapies that we know are actually quite good or even excellent at getting rid of evidence of relapsing disease activity, which from a clinician's perspective, we typically think of as evidence of relapses clinically, or new MRI disease activity in the form of new and enlarging T2 lesions or gadolinium-enhancing lesions. So in part because we have therapies that are so effective at controlling both clinical and paraclinical evidence of relapsing disease activity, we have been able to beneficially affect long-term clinical outcomes in MS. But what has been rearing its ugly head in recent years is that there are still, despite the fact that we've been able to, in many patients, get rid of any evidence of clinical relapses or new MRI disease activity, a concern that has cropped up is that there still are, in many people with MS, ongoing, slowly progressive symptoms. And as we know, MS causes a wide range of symptoms that can impair function and quality of life. Some are much more visible than others. So ambulatory disability is something that we often think about when we think about MS-related disability. But some symptoms that are listed here, including fatigue, cognitive changes, bladder and bowel symptoms, sexual dysfunction, these are all symptoms that we know can happen in people living with MS. And these are the slowly progressive symptoms that we are still seeing, despite the fact that we have a wide range of therapies that are extremely effective at controlling clinical evidence of relapses, as well as paraclinical evidence of relapsing disease activity. So because of the widespread availability of highly effective therapies against relapsing disease biology and the fact that we're still seeing this wide range of neurological symptoms that are often impaired in people living with MS and seem to slowly progress over time, there really in the last number of years has been an evolution in the conceptual framework of how we're looking at MS pathophysiology. We used to think that MS could clearly be delineated into distinct subtypes. We thought that most people present with relapsing remitting MS, and this is mainly driven by peripherally mediated inflammation. And then over time, people can transition into the progressive subtype of MS. And this type of progression is thought to be driven by disease processes that are confined within the central nervous system. And some of these disease processes include chronic, active, or smoldering lesions that many of you have heard about quite a bit in recent years, as well as things like cortical pathology, which includes subpial demyelination, which is driven by meningeal inflammation. So there was a real distinction between relapsing disease biology and progressive disease biology, and it was thought that most people with relapsing disease biology do not have evidence of CNS compartmentalized inflammation until much later on in the disease course. But what's becoming evident again, and this is becoming even clinically evident because of the wide availability of highly effective therapies against relapsing disease biology, we're really understanding that MS is a disease continuum where there isn't this distinct transition period where both of these disease biologies likely play an important role throughout the entire course of MS, even in very early stages of MS. So it's clear that inflammation, whether it's acute or chronic, plays different roles in different compartments throughout the MS disease spectrum and disease course. So again, this is just another slide illustrating the fact that what we historically thought, that it is predominantly one type of disease biology that drives early MS, is not the case. And again, MS is a disease spectrum where you can see both of these disease processes playing a major role, even in early and late stages of disease. One of the first clinical reports that really drove this point home was the first description of PIRA, or progression that is independent of relapse activity, which was a post hoc analysis that was done by Ludwig Kappos and colleagues of the OPERA 1 and 2 phase 3 ocrelizumab clinical trials. So what was very interesting was that this was obviously a group of early relapsing MS patients that were recruited for a typical phase 3 relapsing MS clinical trial. These were the two phase 3 trials that showed that ocrelizumab was much more effective than interferon beta 1A at decreasing both clinical and MRI evidence of relapsing disease activity. But what was really interesting from this post hoc analysis was that when you look at disability progression in general, regardless of whether you're looking at the interferon beta 1A arm, which is displayed on the left here, or the ocrelizumab arm in these clinical trials, the vast majority of disability progression events were related to PIRA, or progression that is independent of relapsing disease activity. Now, the definition of PIRA differs slightly depending on what study you're looking at, but in this particular study, PIRA was essentially defined as a progression event that did not take place in any time frame that was near a relapse event. And so these findings were striking because, again, this was an early population of people with relapsing MS. And regardless of whether you were looking at the ocrelizumab arm or the comparator arm, which was interferon beta 1A, it's clear that PIRA events happen very frequently and, in fact, are responsible for the vast majority of progression events that were seen in this clinical trial. So I think this was a really important paper because from a clinical standpoint, all of these concepts that we've just been talking about really became apparent. And this whole concept of progression that is happening across the spectrum of MS, at least in my opinion, was very clearly illustrated from this report here. Since the first description of PIRA, there have been many additional papers that have looked at the incidence of PIRA, and a really nice one that was done recently was done by Carmen Tur and the Barcelona group. And they have a very well-characterized group of CIS, as you know, that has contributed substantially to our understanding of MS in recent years. And when Carmen Tur and colleagues looked at PIRA in the Barcelona CIS cohort, what they found was that first, PIRA does happen even in people who do not yet have a diagnosis of MS, meaning that even at the very earliest clinical stage, you can see PIRA. And as you can see from the survival curve on the left, you don't see it very frequently. But again, even within a year or two, within the first 5 years of presenting with CIS, about 20 to 30% of people do have evidence of PIRA. So again, illustrating the fact that even in the earliest stages of MS, even before you might be able to say somebody actually has MS, they're very clearly in a proportion of people is PIRA. And then when they looked at the implications of having PIRA early on disability in the longer term, as you can see with the figure on the right, individuals who did have early evidence of PIRA have a much higher likelihood of progressing with respect to disability. So the initial CAPO study, as well as all of these subsequent studies, again, illustrate the same concept that MS is a disease spectrum. Progressive disease biology is often at play in many people, even at the very earliest stages of disease. And having evidence of PIRA has prognostic implications in the longer run as well. And because of this and many other accumulating studies, there really has been a shifting paradigm in how we think about MS in general. And importantly, from a clinical perspective, how we classify MS subtypes. Because again, it's clear that it's not just this relapsing remitting MS that is only driven by relapsing disease biology or peripherally mediated inflammation. And it's not just in later stages of MS that we have evidence of progressive disease biology. It really is a disease spectrum. And as you can see from this diagram here, yes, in earlier stages of MS, relapsing disease biology likely plays a more dominant role. But again, there are people that still have evidence of progressive disease biology and vice versa in later stages of disease. And so because of this growing recognition, both from a pathophysiologic as well as clinical standpoint, this is why there is so much interest in the field on BTK inhibitors or Bruton's tyrosine kinase inhibitors, because this is a relatively widely expressed cellular enzyme that we know has very distinct, important roles in both adaptive and innate immunity. And as we talked about, the reason why we're so interested in this is because we know that relapsing disease biology is driven by B cells and T cells in the periphery that get into the central nervous system. BTK inhibitors are able to modulate B cell maturation, proliferation, cytokine secretion, and autoantibody production. And then many BTK inhibitors can actually get into the brain. And we know that the cellular processes that drive progressive disease biology that are compartmentalized within the central nervous system include B cells that reside in the central nervous system. And we just talked about how BTK inhibitors can beneficially modulate pathogenic B cells. And then we also know that microglia play a very important role in driving progressive disease biology diffusely or around chronic active lesions. And we know that BTK inhibitors can beneficially modulate microglial activation. So theoretically, this is why there is so much interest, because potentially this is a molecule that can actually target both the relapsing disease processes and progressive disease processes that together we know play a role throughout the entire course of MS. So when a BTK inhibitor has properties that enable it to easily get into the central nervous system, and many but not all of the BTK inhibitors under development are able to do this. As you can see from this diagram here, again, we're so interested because in the periphery, we know BTK inhibitors can modulate B cells, which take care of some of the relapsing disease biology component. And then when you can get them into the central nervous system, again, they can modulate B cells within the central nervous system, as well as innate immune cells, including specifically microglia that we know are a major driver of progressive disease biology. So this is the reason why we're so interested, and this is the reason why this entire symposium is dedicated to talking about BTK inhibitors as a potential agent that can address some of the issues that we as MS neurologists have identified in the clinic, and that is still happening despite the fact that we have many, many different agents available. And so the potential of advantages of BTK inhibitors in MS treatment that enable them to maybe address an unmet need are that, again, we know that peripheral B cells play an important role in relapsing disease biology. And then we know that CNS compartmentalized B cells and myeloid cells play an important role in non-relapsing progressive disease biology. We know that BTK inhibitors, again, can regulate B lymphocytes and myeloid cells, making it a really logical therapeutic target for autoimmune diseases like MS, as well as other diseases. And then the key piece that really is this added advantage, and the reason why we're so interested and the reason why BTK inhibitors may address an unmet need is that many BTK inhibitors can cross the blood-brain barrier and get into the central nervous system. And if these BTK inhibitors can do this at therapeutically relevant concentrations and are able to modulate B cells and microglia within the central nervous system, you may have an agent that can address both components of MS disease pathophysiology.
So you've heard about what we think is going on within the brain in our patients, more than just what was going on in the periphery. And now we'll turn to how this actually is playing out in clinical trials. So what have we seen inhibitors of BTK, so the BTK inhibitors, what have they found in clinical trials? I'm going to be just touching briefly on a handful of studies. I don't have time within the limits of this program to go into depth on any individual trial, but just touch briefly on some of the trials that have looked at evobrutinib, tolebrutinib, and fenebrutinib. There are other BTK inhibitor trials ongoing, and so we do look forward to more results over the coming years as our experience with this class of drugs grow. So let me start with evobrutinib. This was first studied in a phase 2 trial that then rolled into open label extension, found a reduction of new lesions in MRI and a reduction in annualized relapse rate. The safety very quickly learned to be one of the most notable safety events is liver enzyme elevations. I'll circle back to that in a moment. This was then carried forward into a phase 3 trial where over 2,000 patients randomized either evobrutinib or active comparator teriflunomide and was not found to reduce annualized relapse rate compared to teriflunomide. Again, the liver enzyme elevations were seen. So this drug is not moving forward because of the lack of superiority compared to teriflunomide, an active comparator, and on the balance of its safety events as well. So this does raise a question about the liver enzymes, and this has been seen in a number of drugs. And so over a 2-year period, we saw 4 BTK inhibitors in multiple sclerosis got put on clinical hold by the U.S. regulators. And there's a couple notable things to appreciate. One is that the severe elevations to date have all been seen within the first 3 months of starting treatment. And we have to remain vigilant and certainly monitoring will continue, but the very severe elevations have all been, to date, seen in the first 3 months of exposure. And we think intensive monitoring, probably weekly, is what will be needed. Intense monitoring can identify them quickly, and importantly, you don't need a magic potion, you don't need a magic treatment. All you need to do is tell patients, stop the BTK inhibitor. So just stop the BTK inhibitor, and then the majority of patients will have a resolution on its own. But of course, you need to recognize it, and you need to tell patients stop taking that medication. And there is a tight window. Again, we will continue monitoring over the long term to see if there are some late, very high elevation in liver enzymes. But at least at this point, it appears with this class that it is an initial exposure in the first 3 months that are the largest risk. All right, so let me turn to the Hercules trial. This was a non-relapsing secondary progressive MS, a 2-arm controlled trial, randomization 2-to-1 of tolebrutinib 60 milligrams compared to placebo. So it's an event-driven trial. So the trial continued. All participants continued on their randomized treatment until 288 progression events, that's 6-month confirmed disability progression events, were observed. And then the trial was closed and patients rolled into an open label extension. I told you this would be a very brief capsule on many of these trials, and so I'll jump right to the primary outcome, and that is that there was a reduction, 31% reduction in the 6-month confirmed disability progression in the patients treated with tolebrutinib compared to placebo. 37.2% of the placebo had 6-month confirmed disability progression compared to only 26.9% in the tolebrutinib, so 31% reduction. A sensitivity analysis was a 3-month confirmed, so patients only needed 3-month confirmed, a little more lax, so a higher proportion of patients met that criteria, 41% in placebo and 32% in tolebrutinib, for a similar 24% reduction in the hazard ratio. MRI findings were interesting. There was a reduction, although modest reduction, in new T2 lesions. As you can see on the left there, placebo at 2.9 and tolebrutinib at 1.8 for an adjusted rate ratio of 0.62, or a 38% reduction in the development of new T2 lesions, a modest benefit by contemporary MRI and MS drug trials. Surprisingly, there was no benefit on whole brain atrophy. So you can see there nearly overlapping curves, or if one wanted to be technical, there was a least square mean difference at end of study of 0.08, which when the overall group decreased about 0.8, it's about a 10 or 15% slowing of brain atrophy, but not statistically significant. So maybe a wee bit of slowing, but not nearly what we would have expected for a drug that slowed disability progression over time. Now, this is quite curious, since we had thought up to this point that whole brain atrophy was a useful biomarker of tissue injury and continued destruction in progressive MS. And we have to rethink that. And it begs the question of, is this just the wrong metric? Should we be looking at something different, like cortical atrophy or gray matter atrophy or slowly expanding lesions? And there are many other imaging metrics. And as you can imagine, ongoing work is looking to identify what is the better imaging metric that corresponds to the clinical benefit that was seen in the overall trial. Turning to safety, that is shown here. Rather similar overall safety profile in terms of serious adverse events and treatment emergent adverse events. A little bit higher individual events in one group compared to another. Is there really more COVID with tolebrutinib compared to placebo? But is there more UTIs with placebo compared to tolebrutinib? I think it's really hard to tell at these very small numbers. But no overall driving difference in terms of these safety events. Turning to liver, of course, we do see a difference. Now, as a reminder, this was a placebo trial, so only 1.6% of the placebo patients had 3 times upper limit normal or higher elevation in liver enzymes, compared to 4.1. So yes, a difference there, but even more so out here, the 20 times upper limit of normal, we see there was a 0.5, or look at it another way, about 1 in 200 patients have a very severe elevation, and all of these patients indeed this occurred in the first 3 months of them starting treatment with tolebrutinib. Unfortunately, one of the patients in this group did need to progress to a liver transplant and succumbed from complications following the liver transplant. So just a reminder that these elevations can be very severe, can be life-threatening if they aren't recognized. Now, since implementing very aggressive monitoring, weekly liver enzyme monitoring in the first 3 months of treatment, we have not seen any fatalities. Although, again, it's just a reminder that this is a very serious risk and needs careful monitoring and quick action. So turning to Gemini relapsing trials, 2 parallel relapsing remitting trials, now using the active comparator teriflunomide, compared to tolebrutinib, 1-to-1 randomization. This was also event-driven. Even though the primary outcome was annualized relapse rate, the event-driven was disability progression. I may scratch your head and say, why was that? Well, it's because both are considered important outcomes, annualized relapse rate and confirmed disability progression. And the goal was to see a benefit, to be powered to see a benefit on both outcomes. And the harder outcome to meet is a confirmed disability progression. And so therefore you power based on that, because if you meet that power, then you're guaranteed to meet the annualized relapse rate power. Doesn't mean your drug will work, but it means you have the potential of seeing if your drug will work by having enough events at the end of the trial. The primary outcome, annualized relapse rate, there was no difference between the tolebrutinib or the teriflunomide groups in either Gemini 1 or Gemini 2. In terms of MRI, this is again where we have a little head scratching with BTK inhibitors. I'll jump over to the right side. New enlarged T2 lesions were relatively similar between teriflunomide and the tolebrutinib, but there was a higher rate of gadolinium-enhancing lesions in the tolebrutinib compared to the teriflunomide groups in both Gemini 1 and Gemini 2. Now, this difference was seen as well in the evobrutinib trials. So there does seem to be something different about BTK inhibitors and the development of GAD lesions versus T2 lesions, something different than what we've seen in other clinical trials. And we have to dive deeper into this. Is it the size of the GAD lesion? What are the characteristics? Are the GAD lesions just different in patients treated with BTK inhibitors than other MS therapies? We really don't know, but we are seeing a dissociation between the GAD and the T2 response that will merit some further attention. Despite no difference in the annualized relapse rate between the two groups across the two trials, a pre-planned analysis of combining the trial data set into one data set, Gemini 1 and Gemini 2, there was a slowing of disability progression. And this is the first that I'm aware that there was a trial that showed no benefit on annualized relapse rate, but yes, a benefit on confirmed disability progression. And you can see here a 29% risk reduction in the 6-month confirmed disability progression, and sort of sensitivity analysis, a 3-month confirmed disability progression. Again, you see a higher event rate because you have lowered the bar on getting disability progression. And again, a 27% risk reduction in sustained progression of disability. Turning to safety, now we're seeing a little bit more of the teriflunomide aspects coming into play, particularly with things like alopecia, but nothing new and nothing, to me, remarkable different from what was seen in phase 2 trials or across this group of this class of drugs. Now, with liver enzymes, overall, we see essentially no difference in the 3 times upper limit normal rate of liver enzyme elevations between the teriflunomide and the tolebrutinib groups. But again, when we look at the very severe elevations, we do see a more marked difference of 0.5% of patients. So again, about 1 in 200 patients having a very severe elevation in liver enzymes after starting treatment with tolebrutinib. And again, all of the cases here in the tolebrutinib treated severe elevation in liver enzymes were within the first 3 months of starting treatment. All right, let me turn now to fenebrutinib. The Fenopta phase 2 trial, we're still waiting for phase 3 trial results, and I'll circle back to the future trials that we're waiting for in a moment. This was a 2-to-1 placebo-controlled trial of 200 milligrams of fenebrutinib twice a day, and then rolled into an open-label extension after 12 weeks of the blinded treatment. Their primary outcome was GAD lesions combined at 4, 8, and 12 weeks. And one can see a nice, robust 69% reduction of GAD lesions and a corresponding 74% reduction in new enlarged T2 lesions over the same period, weeks 4, 8, and 12. Now, what we had seen with the previous 2 BTK inhibitors, tolebrutinib and evobrutinib, was a sort of recrudescence of MRI lesions over the long term after that initial 12 to 24 week period. We're not seeing that with fenebrutinib. We're seeing a continued very low rate of MRI lesion activity here out to week 48. The one caution, though, is to note that there is some dropout And so we've lost about 20% of the patients in the placebo gone to fenebrutinib, and about 30% of the fenebrutinib patients, 65 patients down to 42. So there may have been some informative censoring in the loss of patients. But nonetheless, I think this data is encouraging that maybe fenebrutinib has a longer-term reduction of the peripheral inflammation compared to some of the other BTK inhibitors. And this is showing continued open-label extension at week 48. The safety data, again, nothing really surprising compared to what we have seen with the other BTK inhibitors. Some patients with UTIs, COVID, pharyngitis, like I guess I would count under that. But what we would sort of expect for patients out there living their lives. Now, how do we compare these? We don't have comparison trials, of course, but we have gained a little bit of insight into looking at the pharmacokinetics of these drugs. And so I'll start here on the right side, looking at the plasma and CSF concentrations over time. And the IC90, just as a reminder from that biochemistry class way back in your training, the IC90 is the level of drug that's thought to be needed to have a 90% reduction of the enzyme activity, or the chemical reaction, in this case, the kinase activity of the BTK. So as you can see, it's thought that evobrutinib needs a bit of a higher level, fenebrutinib here and tolebrutinib here. Now, this is just one interpretation, one way of running an assay and of figuring this out. There's no gold standard, but this is one reasonable way of assigning what the IC90 is. And one can see on top here, this is in plasma, and on the bottom here, this is in CSF, that only tolebrutinib seems to reliably get the concentrations in the serum and the CSF up high enough. And here on the left is graphing the max CSF exposure relative to the in vitro IC90. Now, again, in vitro, it's hard to know what that really means in real life, so you have to take this with a little bit of grain of salt. But nonetheless, does remind us that it's important to look at how the drugs get into the brain, and are they getting in at a concentration that we think is relevant. Now, tolebrutinib and CSF penetrance, this is looking at fed versus unfed. And you can see when patients take this drug when fasting, there's a spike and then it drops off quite quickly, where if they take it after having a nice fatty meal, that there is a much longer exposure over time rather than this quick drop-off. M2 is a bioactive metabolite, thought to be the most relevant bioactive metabolite, and again sees the same thing in fasting. There's a quick drop-off, but with fed there is a much more prolonged exposure within the body. Now, this is another study with fenebrutinib. So this IC90 is at a similar level to what we saw on the previous slide, but the values of the fenebrutinib CSF concentration are a bit higher. So this is suggesting that at least a lot of the patients, although perhaps not all the patients, will be having concentrations that are up to the IC90, and all of them having the IC50, which means half of the enzyme or half of the kinase activity is inhibited. And then finally, we do have a bunch of trials that are ongoing. We have the Perseus in primary progressive MS looking at tolebrutinib. We have 2 relapsing trials of fenebrutinib and a primary progressive fenebrutinib. We have a remibrutinib in relapsing MS and 2 phase 2 trials of additional BTK inhibitors. So this is not the end of learning about BTK inhibitors. And as a trialist, I look forward to seeing all these trial results and the compare and contrast between them.
Thank you, Bob, for a really nice summary of all that has been happening in the BTKI world. And as you saw from Bob's last slide, it's clear that this is a really evolving landscape, and likely in the next year or two, we'll continue to hear more about many of these developing BTK inhibitors, which will be very exciting. So at this point, we're going to move on. And given all of the data that Bob just presented, and keeping in mind, of course, that there's many clinical trials still happening, which will inform us further in the coming months, we thought it might be useful to talk about patient case profiles and how we may consider using BTK inhibitors given the data that we have now. And so as you saw from the discussion where Bob was talking about all of these different BTK inhibitors, and I don't think there really ever has been a time in the MS field where there have been so many drugs from the same family that have almost simultaneously been evaluated. But as you heard, there are key pharmacologic properties that are different amongst these BTK inhibitors. Of course, they are all unified in the fact that they do belong to this family of drug, but there clearly are differences in terms of selectivity, the dosing regimen, whether they bind reversibly or irreversibly, covalent or non-covalent interactions, as well as the magnitude of CNS penetration. And so we know theoretically there are these pharmacologic differences. And so the big question that comes up as clinicians is, do any of these pharmacologic differences result in tangible differences in clinical efficacy or safety? And I would say that at least based on the 2 phase 3 trials that have been reported, there are some differences that we see in measures of clinical efficacy. And so this is still a question that, again, it's evolving and likely we'll be able to answer in more detail in the coming years when the results of many of these phase 3 trials are available. But it's unclear as of now, but something really that we need to keep in mind, because some of these pharmacologic properties may or may not make an efficacy or safety difference, but some of them very well may. So these are some questions that we came up with that I think as clinicians we think about as we're facing this new therapeutic era. We don't yet have all the data, obviously, but based on the exciting data that were actually initially presented at ECTRIMS, we may be thinking about these things in terms of how are we going to use BTK inhibitors? And again, the caveat to this entire discussion is that there's many clinical trials that we don't yet know the results for. But based on what we know now, how would you currently use BTK inhibitors? In what MS subtypes? What stages of disease? Where in the treatment course? Would this be a first-line agent, a second-line agent? Would you ever consider using BTK inhibitors in combination therapy? What to do about this liver issue? In people with other hepatic risk factors, is this an agent that could be used? And what do we know about the safety of BTK inhibitors in pregnancy and breastfeeding? And another question that comes up is, what about discontinuing BTK inhibitors? Again, we're in a therapeutic era in MS where we're fortunate because we have so many different choices, and sequencing naturally becomes a part of most people's treatment courses. And this whole issue of rebound has been identified with some disease-modifying treatments. And will this be an issue with BTK inhibitors? And many of these questions we simply don't yet know the answer to. But say there is Max, who's a 50-year-old patient with secondary progressive MS. His brief therapeutic history is as follows. He's actually not currently on any disease-modifying treatment. He has a number of MS-related symptoms, including neuropathic pain as well as bladder symptoms, so he's on oxybutynin and duloxetine for these. He does report worsening of many of his symptoms, so it's a long list, but he specifically says that in the last year he feels way more tired and he feels foggy when he's trying to remember things or think about things. When you examine him in clinic, he's had no evidence of relapses in the last year or in the last 3 years for that matter. We dutifully get an MRI every year and the MRI is completely stable. His EDSS is 4, so this is someone that clearly has evidence of pretty moderate to severe disability. And his EDSS has increased 1 whole point in comparison to last visit. So this is someone that, from a clinical standpoint, does not have evidence of any relapses. does not have any paraclinical evidence of relapsing disease activity and that his MRI is stable, but he is very clearly progressing. And so some questions that come to mind are, based on the data that you've seen, say a BTK inhibitor was available for use in clinical settings. I'm going to pose these questions to Bob. What factors can help determine if Max is a candidate for BTKI therapy? And how does Max compare with the patients studied in available clinical trials? And how would you prepare Max for the expected benefits of BTKI therapy?
So this is challenging because we haven't had this type of therapy before. And so I think we need to, based on the trials, treatment with an oral penetrant BTK inhibitor appears to slow progression of disability. And so I think we can say we can slow down the decline with this. There are some risks, and you need to be willing to step up to the very intensive monitoring. And based on your age, your disease characteristics, you fit within what the trial studied, but it doesn't mean you will respond like the average trial participant, because some patients did progress even though they were on treatment, and other patients did not progress even though they were on placebo.
So, I think as Bob outlines, this patient profile is actually one that is in keeping with what was seen in the Hercules clinical trial. I think this piece about expectations is really important, though, because I think as clinicians, when the first treatment became available, say for primary progressive MS, which was ocrelizumab, this is a discussion that obviously you have often. And then a question that patients often ask is, what can I expect? And as Bob said, it's tough to say because we know that in the large clinical trial where there were nearly 1,000 patients, we can say definitively that this was an agent that did decrease the risk of disability progressing. And in fact, in a proportion of people, there was evidence of disability improvement. But in an individual patient, it's very difficult to say what exactly we can expect in the next year or two. And so I think, as Bob said, some people, the whole goal is really we know that it decreases the risk of disability progression, but whether that means someone will actually be stable or the trajectory of disability progression will be less steep than it was before, I think it's difficult to say. So, Bob, say you decided to go ahead and the patient was open to the option of a BTK inhibitor. How would you discuss potential benefits and risks with this patient? And how would you monitor therapy?
Well, again, I would say that it appears this drug can slow the likelihood or the probability of having progression, although we'll never know for sure if the drug is working, just like our other MS drugs. And patients are sort of familiar with that because they know when they started the relapsing MS drug, there was no guarantee and there wasn't a clear way other than, am I still getting relapses? Am I getting new lesions in MRI? So it would be monitoring their progression and monitoring, again, you've heard us talk about the liver enzyme. That's one of the most important aspects. But we'd also look at other aspects like infections because we're still trying to figure out, is there an increased rate of infection with this class of drugs and other safety issues as well. So like any new drug, there's a lot we don't know about, a lot more we don't know about now than we will in 5, 10, or 15 years. So the uncertainties are much higher.
And this is actually a question that has come up from a number of people in the audience. One of the most popular questions that all of you have submitted is this question of biomarkers in clinical practice. How do we monitor for PIRA? How do we monitor for progression? And so in someone like this, Bob, do you have access to anything? Would you change anything in terms of, you see them in clinic, we all do our EDSSs, anything else?
Yeah, so I'm a bit pessimistic about the current biomarkers, whether they're imaging or fluid. I don't think any of our current fluid biomarkers like GFAP or neurofilament are going to be helpful here, at least not in a reliable way at the individual patient level. So I would do what I do with most of my patients. How are you doing? How are you feeling? And we don't have a many you that we didn't put on therapy or we didn't do whatever we just did. So we just have to lump it along as best as we can.
And one last question. Earlier we talked about this piece about expectations, and it sounds like there's many different biomarkers cooking, but as Bob said, access is an issue, and we don't yet have the clear evidence to use any one of these biomarkers, whether it's a fluid biomarker or some of these more novel imaging measures in clinical practice. But in terms of that expectation piece of what to expect in a patient, and you already talked, Bob, about how you might say it's unclear how an individual patient will respond, but sometimes you can see disease stability. Sometimes you may see less worsening. Do you ever talk about that disease improvement piece?
I don't, because I'm nervous about it. I know patients can improve, and some of them do, but I'm hesitant to set expectations that are frequently not met. Now, their proportion with improvement is not high in either the relapsing or the progressive trials, but are not zero either. But if it happens and they come back and they say they're improved, I say yay. Oftentimes they've started an exercise program, or they've changed their diet, or they've lost weight, or they've done something different as well that I think has probably helped to bolster that improvement.
So, it's a fine line. I think that setting expectations, and particularly in the clinical setting where we don't yet have access to some of these more, say, objective or reliable biomarkers, it is really challenging. But, even though it's a small proportion, I have to say I do talk about the possibility of improvement, because even that small glimmer of hope can be really valuable, with the caveat that we absolutely do not know how an individual patient will respond. It could be disease stability. That would be great. It could be less worsening, which is out of the three outcomes, probably not as desired, but still better than nothing. And then I do talk about how there is still the possibility of a small benefit in a proportion of people. And so the goal will be to monitor people closely over time using the available clinical tools that we have.
Just to summarize, the role of B cells, microglia in MS pathophysiology has prompted us to go to BTK inhibitors and explore them. We have had promising outcomes in phase 2 trials and phase 3 trials, so work continues to explore BTK inhibitors. So what is the optimal imaging strategy to monitor smoldering neuroinflammation? We don't know. Slowly expanding lesions may be an optimal one, but we don't know how best to manage that smoldering inflammation.
And as you well know, you've heard a lot about paramagnetic rim lesions and slowly expanding or evolving lesions. These are being evaluated in clinical trial settings, but in an individual, access is an issue, and we actually don't know how to use these measures to monitor for smoldering disease, but hopefully there will be something in the coming years.
What data exists that link the pathogenesis of activated microglia directly to clinical signs and symptoms? So that's very easy. We don't have the data to directly link it. We think it may be related. There's probably a lot of things that add to that. And so it's just a presumption that they're in part somehow connected.
We do have a pretty specific question. Would we expect BTK inhibitors to reduce oligoclonal band presence if it is having a CNS penetrating effect? So theoretically, possibly, as we talked about, many of the BTK inhibitors can get into the central nervous system at biologically relevant concentrations. And we know that there are resident B cells that generate some of these oligoclonal bands. So it is possible, but I don't think we have any evidence as to whether this happens or not based on clinical trial data as of yet.
Now, I'm going to be a pessimist and say it probably won't, because those oligoclonal bands are staying there and are unchanged for life and probably are not changed by therapy.
Let's see. One question, I think this is more of a clinical practice question. When these treatments go to market, how do you feel clinicians and patients will accept weekly liver monitoring? Will that limit your prescribing due to the burden?
I think given that it's only for 3 months, that is helpful. So anyone can do anything for 3 months. They can't do it for 3 years. And it'll just be a requirement. You got to do it. If you're going to do this and you want to live, this is important for you. 1 in 200 is pretty high risk. And the encouraging part is as long as we recognize it and stop the drug, the outcome is likely to be quite positive. So I think it will be a conversation that we can have. Some patients will say no, and okay, well, then this isn't the right drug for you.
And I think one thing that Bob said really important, it's for a limited time period. I don't think we yet know what the label will look like. And obviously, as clinicians, we'll need to follow this. But yes, weekly monitoring can be a big burden. But as long as it is for a limited time frame, definitely doable, especially if there is an unmet clinical need that's addressed. And then just also wanted to emphasize, in the MS field, we're not really that foreign to issues with liver issues, just because many of our existing treatments, even now, even the older interferon beta agents, we know potentially had an issue with liver enzyme elevation. And so this is something that we actually relatively frequently do in clinical practice and will simply require a discussion with patients. Just also wanted to touch on the fact that some of this cumbersome lab monitoring, there are ways to make it easier for patients. Sometimes there are, home services that can go and draw blood. And so these are kind of practical considerations that hopefully we'll be able to navigate through so that we can make the monitoring piece not an obstacle to prescribing inappropriate patients.
Do you anticipate using BTKs in combination with other DMTs? I think yes. BTKs are not a very effective peripherally acting anti-inflammatory. And probably will need to be combined with something else. We haven't done studies, so we don't know how to do it. We don't know the safety issues, liver enzymes being one of the principal things we worry about, but also potentially infections. So we don't know. But I do see in 5 or 10 years, we'll be using these in combination.
Just with the combination piece, though, I think one thing that is always a rate limiting step is the cost behind it. And so I'm a little less optimistic about whether we'll be able to use combination therapies because the cost will be truly exorbitant, especially I think here in the United States where the cost of medications is even higher than around the world. But what I think we can do is consider really smart sequencing strategies. For instance, we know that B-cell therapies can often have longer lasting effects and maybe treating for a while and then quickly switching over to a BTK inhibitor may be a strategy that many of us can employ.
All right. And then there's a question about subgroup analysis. And yes, we are looking forward to subgroup analysis from all the BTK inhibitors and understanding what types of patients it works in and what are the characteristics of the responders versus the not. That is still in the works, and we look forward to seeing those in the coming months and years.
So stay tuned.
Stay tuned.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Sanofi. To access all materials for this activity, visit peerview.com/DWJ860.